Thank you very much for coming to this symposium, about which I am quite excited because we have managed to gather three very wise men to talk about teaching people about pain. The format of the next 1.5 hours will be like this. I will give a brief introduction as to what we think the biology of pain looks like. And I guess that provides the biological model from which each of these three people is working. So after that, we'll move on to, is it you, Adrian? It's David. This is a very well polished and planned symposium. David Butler will be talking about integrating the process of explaining pain biology in the real world and looking at some really interesting work he's been involved with, looking at how do we get people to change their minds about things. Adrian Loan will be talking about the evidence for explaining pain, and then some recent work he's been doing looking at surgery and post-surgical stuff. Mick Thacker from King's College London will tell you about the process of explaining pain, reconceptualising pain for clinicians. So he runs the Pain Science Masters at King's College in London. And if there is any time at the end, I will return and tell you a bit about some recent things that we've been doing. I think if we have time, we'll have questions after each person talks, but hopefully we'll have time at the end as well. So that's the plan. We sing a song in our house, and these are the words of this song, and I think the crowd is probably too big to try and orchestrate a joint rendition of this. But if you want to go home and practice, the chorus of this song goes like this. René Descartes was very, very smart, which is why we sing this song. But I must impart he was a jolly old fart, and as it turns out, he was wrong. Thank you. This is a drawing done by René Descartes in 1654, and he proposed that there is a hydraulic system that runs from the point of your body that is in danger to your brain and tells your brain that that point is in pain. Now, hopefully no one in the room believes that we have a hydraulic system that rings a bell in your brain. René Descartes attributed it to ringing the bell in this situation, on the foot of the little man in your brain. And there were two fundamental errors with his theory, although it was terrific at the time. The fundamental errors were that there was only a little man, which meant that 50% of the population, we still don't know how they work. So the homunculus is the little man, and then he had the problem that how does the little man know that his toe is in pain? Clearly there must be a really little man inside the little man, and then there must be an incy-wincy tinsy man. So you can see the problem that René Descartes already identified. Now we don't believe that, but it is very intuitively attractive and seductive to adopt this slightly and suggest it's electrical circuits. An electrical impulse carries the pain message to the brain. Now, René Descartes was very, very smart, but as it turns out, he was wrong. If he was right, we would be able to rely on data like this. This is from the 1960s. If you put a very hot thermode on the back of someone's hand, it hurts. There's my red dot. Did I get a red dot? There it is. Isn't that lovely? It hurts, and if you keep the thermode there for 30 seconds, it hurts for 30 seconds. But if you record activity in C fibres, they do something different. So this is the activity in C fibres with a hot thermode on the back of your hand. If you were listening to this, it would go like this. If one was to pretend that this is the hot thermode, your C fibres do this. Blip, 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 blip. blip, blip, blip. Can you see the thermode is still on the back of your hand and it still hurts? So this was quite confronting until physiologists discovered A delta fibres, because A delta fibres do something slightly different. They do this: plop, 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 plop. Okay, note the thermode is already on my hand. Plop, 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 plop. So the physiologist thought, aha, pain equals C fibres plus A delta fibres, because clearly plus plop, 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 plop equals diddle plop, diddle plop, diddle plop, diddle plop, diddle plop, diddle plop, diddle plop. That was the theory. Unfortunately, it is nowhere near that simple in the real world. How normal are the people who volunteer for these experiments? How realistic are the stimuli that we deliver? I've been to many countries in the world now, and I'm quite fascinated with toilets. When I first went to the toilet in the United States of America, where you have about 4 times the volume of water, and I absent-mindedly leant forward, which starts the flush, and all of that water gushing down. I thought I was being disemboweled. However, how realistic is it? We do experiments where we inject salty water into the muscles of the pelvic floor to induce pain. How realistic is that? Nowhere have I been to the toilet and have I received a sterile injection of hypertonic saline on sitting down. It's not a realistic thing. We have to make the distinction between nociception and pain. This is the nociceptive system. We have nociceptors in the periphery. We have things called spinal nociceptors that run from the dorsal horn up to the thalamus and then onto the brain. We have extremely well-developed and complex descending anti-nociceptive systems that incorporate midbrain structures, the most famous of which is the periaqueductal grey matter, the PAG. And the periaqueductal grey can give us descending inhibitory input to the spinal cord and is a very powerful anti-nociceptive device, and descending facilitatory input into the spinal cord and is a very powerful facilitatory device in the nociceptive system. All of that we could categorise as nociception, danger, reception and transmission. Nociception happens without us knowing about it. It's possible to have severe noxious input and not know about that. We can activate all sorts of processes without knowing. We can change immune responses, cardiovascular responses, motor responses, endocrine responses. All of that can be triggered by noxious input and activity in the nociceptive system. Nociception is happening right now. You all have messages coming from your bottom. They're coming up to your brain saying there's danger in your bottom. Danger in your bottom. And none of you knew about that until right now. And then you would wiggle. And most of you will be wiggling and changing your position in response to noxious input, activity in the nociceptive system. René would have us believe that pain is a conscious version of nociception. René Descartes would have us believe that. And if he was right, then we would see this scenario: that pain corresponds with activity in C and A delta fibres across the board. And we would also see that as nociception increases, pain increases. And you all know that this is not how it works. And there are studies, this week, there are many, many studies you could look at that untangle the sometimes very tenuous relationship between nociception and pain. And we've known this for 50 years. So René would argue that nociception equals pain, or that pain equals nociception reaching awareness. And if we subscribe to these sort of things, we can quite easily use terms like, you didn't realise you had pain until you looked at it. Now that's a nonsensical statement according to modern pain science, but it's very sensible according to René Descartes. because René Descartes' theory can say you have pain in your body that's transmitted to your brain, telling you that damage has happened or damage is about to happen. I showed this, I think, at the opening ceremony, this visual experience. Now, hopefully you all saw that. In a split second, your brain tells you that there are two grey panels and that they are different shades of grey. And you did not know what was happening before you got that experience. So the brain does all this groovy stuff and then would have shown you that very quickly outside of your control. This is visual experience. And what you're seeing is not the truth, because when we remove a key piece of the picture, clearly those two grey panels are the same. But your brain changes the message. It gives you a visual experience that is biologically advantageous. We could call this a biologically advantageous visual experience. What really happens? The message hits your retina, goes to the back of your brain. Your brain does an amazingly complex thing and then gives you a visual experience. With pain, it's the same. A danger message arrives from the body, sometimes quite a complex danger message. A whole lot of amazing things happen, and hopefully your brain will play the pain tune. And hopefully your brain will play pain in your leg tune if the danger is in your leg. But we know there are situations when the brain might play the pain in your leg tune when there is danger in your back. So we subscribe to the idea of pain, and this is not our idea. This is just the idea that others have formulated over the last 50 or 60 years, to which we subscribe, and that is that pain is a reflection of your brain's evaluation of danger to body tissue. How dangerous is this really? Conceptualising the biology of that, we could say there's the neural network of pain, and important modulators of that are beliefs, and we can just go through a lot of different things and put them all into your brain, the output of which might very well be pain. And you can modulate any of those inputs. And the only one that I haven't put in there is probably the only one that people are extremely comfortable with, and that is nociception. It's very important, very important. Nociceptive input comes up, and the rest of the stuff happens inside the marvellous network of neurons. So this is what René would have, and René concentrates on the peripheral nociceptor and I guess the spinal nociceptor. In the other corner we have three wise men. From your left, Lord Michael Thacker, Earl Adrian Loan and King David Butler. They suggest that pain incorporates the entire system, and Mick Thacker will probably suggest that, as he always does with a very astute observatory power, that I am neurocentric, I'm concentrating on the nervous system here. In reality, these three wise men subscribe to the well-established theories that pain is about the entire system, not just the nociceptive system. That's hopefully you understand the biological model to which we subscribe, and we would argue by which humans work. The only way we can study the nociceptive system in isolation is to remove the brain, and that has severe ethical implications. I would now like David Butler to come and tell us some wise things. I'm sure that there are very few, if anyone, in the room who doesn't know David in some way. David has been an inspiration to me. I remember going to a physiotherapy conference in 1995 because it made my surfing trip tax deductible, and I sat in the front row as this fellow was trying to extol the virtues of thinking beyond the tissues when we're trying to deal with patients. And this was somewhat controversial in that community at the time. And at the end of the talk, I yelled out, "You beauty," or "All right." And it was silent aside from that. But that's when I met David. And since then, I've got to understand a great deal of stuff about the nervous system primarily. And David really has driven a lot of that. He is a clinical educator. He has a doctorate of education in conceptual change theory. He's inspired many of you, I'm sure, and he expresses that stuff primarily through his company noigroup.com, which I'm sure you're all familiar with. David, come and talk to us.
Thanks, Lorimer. You know, the first thing I noticed, remember, Lorimer, it was only 6 years ago. We gave our first explained pain course in Sydney, and 9 people rocked up. And I thought, geez, maybe we should go back to that muscle stuff or crack a few bones. But thank you all for coming. That's a great honour. You will notice a couple of things when I lecture, that I'm in this team, I'm the fashion guru, I'm the stylist. The others, when they get up, they've got lovely brains, reasonable bodies, but don't be too excited about the fashion. I'd also like to say, so nice to be back here in Holland, because I've taught here a lot over the last quarter of a century. Some of you have got very old, but it's nice to see you again. Lost a lot of hair. It's just lovely. Thanks. Anyone from New Zealand here? Put your hand up. Okay, we'll go a bit slower. It's all right. We love you. So I'm going to talk a little bit about the physiotherapist as a therapeutic educator, the science of conceptual change, because to take this knowledge that Lorimer has started and the others will continue with, you need specific skills. You need to be aware of the evidence, to have that good, strong feeling with a patient. Yes, I can sit down and tell you something about how your brain and body and pain and stress systems work. You need, I believe, to know where it all fits. It doesn't fit, for example, in cognitive behavioural therapy. It's much, much bigger than that. You need to know too, I believe, that educational conceptual change is not just for your patients, it's for us. We know more about how the pain system works in the last 10 years than in the 1,000 years before. I believe we all have a moral responsibility to update our education. I believe you need a bit of educational science, and you need some educational ammunition, or ammo as we call it. You've got to have something to fire back, to talk about, your treatment tools. We four are really influenced by Patrick Wall, and he used to call physiotherapy the sleeping giant. And I think it's absolutely apt that the sleeping giant is now ready to go. My little piece of the talk is knowing where it fits, giving you a paradigm to fit this explained pain material. I'll give you some little bit of educational science and a little bit of ammunition. So where does it fit? Here's a new term for you. I believe we push it under this thing, new biopsychosocialism. It sounds a bit Marxist, but a little bit of socialism is good for us all, okay? And new biopsychosocialism is refreshing this thing with the power of knowledge. Physiotherapists worldwide are known to have and use 2 mental frameworks in their management of pain states. We use a biomedical and we all use, some degree, a biopsychosocial approach. What is it? Biomedicalism. This is the find the germ, the virus, the fracture, get that joint, get that one single muscle, get the gene, the tumour, kill it, fix it, strengthen it, whatever. The approach is intuitive, it's successful for many diseases, and let's say here, let's be grateful for it, because many of us are alive today because of it. But the biopsychosocial approach, which merges this biological, social and psychological contributions to pain states, is quite new. Only 35 years. Moderate outcomes in pain management. And I'm going to try and push you to it, and you think, well, why? Classic examples out there of the 2 versions are the therapist who has a patient, in they come, back pain, and they'll think, is it a disc, is it a muscle, is it a nerve, is it a joint? And then 2 or 3 weeks later they'll realise, hang on, this is not getting better, this is a bit slow. The patient's taken on a lawyer, a few problems at home, their pet dog's got total body ringworm, there's all sorts of things happening here. And you then tend to move to something more biopsychosocial. Whereas we're going to argue that this dualism, indeed all dualisms are harmful, that the dualism of the 2 thinking is holding us back. And I'm going to push you, welcome you, come to biopsychosocialism. And the reason you should is that biomedical approaches do not work. For the chronic disease states, like chronic obstructive airways disease, diabetic neuropathy, chronic pain, chronic stress. And if you think they work, well, take this. Chronic pain costs the United States much more than the 2 wars in Afghanistan and Iraq do. Imagine how many wars we could be in if we had no pain. But biomedicalism does not work. Take that next paragraph. Or anywhere there's numerous causes, or where the disease state depends more on a person's actions and beliefs than the actual initial cause. These approaches have moderate success, but new biopsychosocialism, adding the neuroscience, will do it a lot better. Just make sure you get it. Biomedical on the left, biopsychosocial on the right. Just take a look. The first one, biomedical, it's that search for a cause, whereas biopsychosocialism will recognise multiple causes. Drop down 3 or 4 levels. Look, patient management often passive in biomedicalism. Patient management more active. It doesn't neglect passive treatment, but self-management is critical. Biomedicalism relies on curative monotherapies, where biopsychosocialism more rehabilitative. And look down the bottom. Biomedicalism may fail to recognise preventative medicine. Yet biopsychosocialism, it is a critical part of it, that it includes psychosocial and physical factors as precursors to injury and disease. Now, the key slide. Everybody, deep breath, tune in. The bio in biopsychosocialism is the biology, anatomy, physiology, etc. of the physical mental state, or said body and brain too, and the unity of it. The psycho recognises the critical role of psychological factors in function, which are increasingly being biologised. For example, we know some of the chemical substrates of catastrophisation. And social recognises the importance of social context. So note clearly, the bio in biopsychosocial is not biomedical, but it's everything biomedical is and more, because it embraces the brain and representation. Biomedical thinking can fit into biopsychosocial, but the reverse is not possible. Biopsychosocial practice will welcome biomedical practice. It loves it. You can give an injection, crack a neck, do an exercise. You can do it in a biopsychosocial way. So for my young student who might be making something a bit stronger and a bit longer, I would want that student to see that that is essentially a way of avoiding threat in society. And I would want that student to try and work out what were the societal threats, whatever they are, that caused this change. Biopsychosocialism is enriched by modern neuroscience, the paradigms of matrix, neuroimmunology, new biopsychosocialism, and this is where we extract the rich narratives. The educational ammunition we'll give you some of for explain pain and similar strategies. Now, one last go to get this in, Biopsychosocial approach is the heuristic for pain management, the rule of thumb. The textbooks say it, the randomised controls trials say it, the systematic reviews say it, the Delphi studies say it, respected opinions says it, it's neuroscience backed, the International Association for the Study for Pain back it, the World Health Organisation backs it, Al-Qaeda backs it. We should all be backing it. And this is where education fits, this thing which we talk about. Education, for me, for our colleagues, the most potent pain liberator of all. And it's education which is the foundation of modern biopsychosocial thinking. But it's a particular kind of education, not the old-fashioned stuff. It's more biological education. And once again, it's not just for your patients, it's for you as well. And may I remind you that in the world, it's estimated that approximately 1 in 5 people have a pain state that doesn't go away. Therefore, it qualifies for epidemic status. And in the past, what has helped epidemics? Of cholera, of AIDS transmission? It's essentially knowledge. Okay, I'm going to give you a little bit of educational science. Just a little bit. The first thing is, when you're with a patient, to help you size up unhelpful knowledge, try and categorise it. And when you have a patient, the spectrum of knowledge enrichment when you educate, it will essentially goes from knowledge enrichment to needing to challenge information, unhelpful knowledge, which is in what we call different grain sizes. So knowledge enrichment is a piece of cake. as long as you have the knowledge. Sometimes you educate patients and you think, this is so easy. The patient's like a sponge. You know, it's all nice. You're filling in the gaps. You're non-weight bearing. You have a little story about tissue healing times. And you've all done that and you think, I could be an educator. But then in comes the next patient. Patients sometimes have unhelpful knowledge, but it's held in a single grain of unhelpful information. Just a single little blob. It's not attached to anything else. It could just be a heuristic, like the older patient who says, you can't teach an old dog new tricks. Well, in Australia we say that is bullshit. Old dogs can learn new tricks right until the last breath your brain will change. Or it could be somebody with night pain who's gone and Googled it. And if you Google night pain, it's not a pretty story. You're told you've got some nasty tumour. Whereas night pain could be, in a certain state, a feature of a peripheral neuropathy. Or something the patient who says, oh, my knee, it's just old age. Now, single grains are easy to challenge. For example, I might say, well, is the other knee the same age or older? What's going on there? We'll make it a bit younger for you. We'll even them up. This little bit of dissonance, playing with the story, is a critical part. Many patients, however, have multiple grains of unhelpful information, but it's held together in a coherent concept. We call it the sandcastle. And I make it the sandcastle because all these grains, actually with the skills, you can wash the sandcastle away and break down the concept. And this sometimes includes useful knowledge too. Why don't I tell you about a failure? Just to give you an example. Last patient I consulted on when I left Australia, 9 years of chronic lateral leg pain in the fibular nerve distribution and with a bit of spread up in the back. Someone convinced her, some mad doctor convinced her that she should have the fibular nerve cut above the knee. I tried to convince her that that's not the right thing, but she had formed a concept. She'd had a block. It worked. Oh, it was so beautiful for her. Why not cutting it? The notion of just cutting this thing like the cord on the television set fitted for her. The doctor had an information sheet about an operation done in some far-flung country that it worked. And she went ahead and had it, and now I've got her back much, much worse. But I couldn't break these little multiple forms of grains for her with this overall unhelpful concept. Another example. A patient who I had who couldn't work Wednesday. Now, the key thing is here, you can't say, what do you mean you can't work Wednesday, you fruitcake? Just get your diary and change the number on top, the name, make Wednesday Tuesday. Because that won't work because I'm attacking him at the concept level. But if I went underneath for the grains constructing it, I would find there's a fatigue issue, there's a supervisor issue, there's other notions which I can slowly break down this notion of not working Wednesday. Many of the yellow flags are essentially held at this grain size. But the key thing is, if you get underneath them, you can usually break them away if you take the little pieces of grains away. However, we all have patients where the grain size is held together, welded together in sandstone, stuck together. Strong paradigms. The person who believes in one health practitioner all their lives. Or a classic example is my brother. Breaking the rules of never treating family, my brother had an accident out in outback Australia. He got hit in the neck with a machine while playing with a wool press, pressing wool. And he essentially got a whiplash and a broken jaw and a few things. And I knew he was struggling about a year or so later. So I sent him a copy of Explain Pain. I said, read this, this will fix you. 2 weeks later, Dave, I read that book. It's bullshit. My pain is completely different. Don't talk to me about the brain. It's in the neck. He's got quite a strong paradigm held here. And so I managed to find him a therapist who was particularly biomedical, who believed the neck was just a little block with a few joints to tighten up, and my brother went along beautifully with him. Key point, you need to get them better within the paradigm. Picking up the grains. How do you pick up the grains? Well, in education, all manual therapists, all of us, have listened to stories from patients and picked up the information about physical things. But you can also pick up the information about the unhelpful beliefs as well too. We call these the E flags. A typical patient, 6 weeks of back pain, about to tumble into a life of chronicity or get out with your help, might have 10 E flags. My shoulder cracks, why hasn't it got better? Nobody believes me. Is one leg really longer than the other? Etc, etc. And we collect all of this information. You need the knowledge to do it. And the clinical reasoners will do best, because those seeking for patterns will find more knowledge to drive their thinking. This is what I get my undergraduates to do now. I've gone back to undergraduate teaching. Postgrads, brain to set. A lovely, fresh, plastic brain to put this on is an absolute joy. Every little E flag here would sit as a little signature up in the brain, as Lorimer pointed out here, and you can take them out, squirt them, zap them with a little neuroscience nugget, spot of information, if you've got the ammunition to desensitise pain signatures. But all of this doesn't tell us how hard it is to change. And I'll briefly take you through a model for change. Based on educational theorists, I want to try and convince you, using this model here, for example, a patient, that much of their pain state might exist in brain circuitry. The most popular image in Explain Pain. Some of you have seen it, I'm sure. On the left, you can see how there's a protect by pain line up close to the tissue tolerance. If you climb the mountain, when you start to challenge tissues, you're warned. But over on the right, there's a new protect by pain line that people set, their brains set, in response to all of these inputs, which Lorimer has picked. This is no different to convincing someone they shouldn't smoke. This is no different to convincing someone they should exercise. Same principles. Our Spanish colleagues will tell you what that means. So you go in and you present your conceptual change message. The first thing you will get will be, well, we call it piss off, I'm afraid, or in Australia, something that sounds like fire truck. There's no change. Go away. Who are you to tell me? With your orange glasses and your funny shirt. 4 orthopaedic surgeons, 2 neurologists have told me it's disc on disc, bone on bone in there, and you're trying to convince me it's something more. It's not easy. But many patients will listen. With their brain will absorb it with a bit of interest, challenge and threat. Or the word is the brain begins to elaborate. The information is taken and put through the signatures in the brain. And here is where we see a phenomena called Explain Pain, Pain. Dave, I read yours and Lorimer's book and it made the pain worse. I got to chapter 3 and broke out in a sweat. Isn't that delicious? The notion of even the knowledge is a threat. 2 pathways of elaboration may follow. This is what we call a deep pathway, where the patient thinks, yeah, I'll give you the go. I like the way you've done it. They're nice glasses. I'll give you the go. But that little thought is the most delicately, easily knocked off schema. They'll leave you and some dinosaur will tell them, no, it's not like that. They'll see something on the net. On they go. This is what we call the deep learning pathway, where knowledge is actually a treatment tool, where you want them to go with yours and other help through in-depth processing, reflection of message and behaviour change, which might simply be someone saying, okay, you told me it's more the brain, not so much the tissues. I will do a little bit more even though it hurts. Oh yes, it's hurting, but yeah, the mother-in-law was here on the weekend. Okay, you said these thoughts and feelings can impact on my pain. Okay, that makes sense. Reflecting. The data is that a few people might go on to true conceptual change and learn from it, or as we all know, there's a patient who's been with you for a while and then rejects it, goes and have the spinal fusion despite their little evidence for it, or is on an anti-smoking program and then goes back again. We estimate in the world maybe 4 or 5% are going on to true conceptual change. Most people will go on to a weak change, a very weak change. It's called the peripheral pathway, where they exist with superficial processing on the information and avoidance. They miss appointments, they come late. It's more important to get the children off to netball. And they exist on little rules of thumb. Got a pain, I just don't have it cracked, or something like that. The data is they may never go on to much. Only a superficial conceptual change. Now I'm almost up, aren't I, Loz? Okay, I'll finish with this note. It is hard though. And I like to put up this cartoon, drawn by a very skilled therapist. So how's the therapy going, Ted? It looks like you're still in pain. Yeah, my back's killing me, but the good news is we know what the problem is. My brain still thinks I'm being damaged, even though the area healed a long time ago. It's that fight or flight thing. It's like my brain thinks something's still hurting after all this time. How silly is that? I'll be better. I've got to teach my brain that nothing is wrong, so it'll chill. Yeah, good luck with that. Crocodiles exist. And I've got to tell you, my colleague Peter Roberts here, we teach our postgraduates. I do this on postgraduate education. And a great learning experience, Peter brought in one of his patients who was the best ever performed, who'd done really well with a skilled pain management program. And the patient was out the front with the students, and the students could ask the patient anything they wanted. One smart student leaned forward and she said to the patient, "I know you've done really, really well, but do you really believe in your heart that there's nothing wrong with your back?" And the patient thought and thought and thought, said, no, I can't let go of it. It's always there. And why would it change in the brain with this particular experience? I will leave you there to say it is difficult. We're making progress. Let me hand you over to Adrian. It's my pleasure to introduce Adrian Loan. Adrian's from the United States and well known to many here from the States. He's also a PhD student. He's almost there, doing some very revolutionary work in taking neuroscience education to a particular field. And when he started this PhD, I thought, my God, Adrian, that's the toughest thing you're trying to challenge, to try and change the thoughts and beliefs of surgeons. Let me hand you over to Adrian Loan from the US.
Thanks, Dave. You'll notice I'm the junior partner of the firm Butler, Moseley, and Thacker because I have hair. And so, sorry, I'm the new one on the block. So, thanks for having me, Lars. All right. My goal this afternoon is to talk to you guys a little bit about the evidence for neuroscience education, basically applying the stuff Lorimer, David, and Mick has talked about so much, and Mick is going to talk about it a little bit later on. So I'd like to just share some stuff that we've done in our research and tell you guys where we're going. The first thing I need to mention is the fact that we've been using neuroscience education for quite a while. Lorimer Moseley is obviously well known with it and has done a ton of these. I realize I don't have all the references in there, but it would take about 79 slides to put all of Lorimer's studies in there. But this has been used. The notion of taking knowledge to patients, a neuroscience knowledge, and it's been used out there. Recent studies have also added case studies. Other scientists, especially in Europe, have used some of this, primarily for patients with chronic back pain, whiplash, chronic fatigue syndrome. And so a lot of these studies are out there. The question just comes out, what's the evidence? And we've all seen this. But before we go there, I want to show you guys just two very simple examples. A lot of you guys have probably seen this, but we think this is powerful. This is amazing stuff when we show this to therapists. I think the first one is the one by Moseley. Widespread brain activity following neuroscience education. A lot of you guys have seen this, but I cannot stop looking at this all the time and thinking, how amazing is this? Showing patients this. Not going into the details of it, but what you guys see there is a functional MRI scan of a patient with about 4.5 years of pain, cannot work, lots of pain all over the body. And without trying to interpret it, Lorimer is sitting here. You can see the brain's extremely active. And in the way we interpret this is the brain is busy activating many areas of the brain, the neuromatrix, dealing with this threat, this thing called pain, struggling with it, not knowing what to do. And after about a 3.5-hour session with Lorimer in a room, the brain basically calms down. The activation has desensitized, if you will. Now, for the neuroscientists in the room, apologies, we know we're taking major liberty interpreting probably a lot of these scans, but with Lorimer sitting here, and he's probably going to mop up after I'm done, so easy way to explain. But how amazing. You guys see patients every day coming to your clinic. There's a lot going on. They're very worried, very nervous, a lot of things going on. But through these educational programs we do, we can actually calm the system down. And the research shows that if we do this, they will move better, function better, do your exercise better, allow you to do more stuff with them. Sorry, I have to throw this one in. This is a case study we just got accepted for publication. And I want to show you one of my patients. Here she is. She's bending forward flexion, about 10 degrees in forward flexion. After a 75-minute neuroscience education session, the fear avoidance belief questionnaire drops down drastically. And basically 75 minutes later, after no manual therapy, no exercise, no clockwise ultrasound, nothing with her, she's moving a lot better. The only sad thing is she stayed blind. You can see she's still blind. But we couldn't fix that. I'll let Lorimer fix that later on. So the question comes up, these are case studies, and we realize that. And I understand there's scientists in the room that saying, yeah, they're case studies, single case studies, but I do want to make a comment that something Lorimer mentioned at a conference recently, and that is, think about it. We say case studies, lower level of evidence, but imagine that's your mom. That's your sister. That's your friend, your best friend in the world that's suffering from pain, and we can make these changes. So we have to also look at those patients. To answer the question about evidence, we've done a systematic review, which is now under review. Hopefully, I'd really appreciate if anybody in this room can say a prayer as we do the presentation. We'd like to get this published. We've submitted this full publication, a systematic review on the efficacy of neuroscience education. The patients that this has been done on in the neuroscience education is primarily middle-aged females with pain about 2.5 years out, which fits with our patient population for chronic pain. By the way, if you ran a statistical or epidemiological look at fibromyalgia as an example, you'll find the same results. Middle-aged females, pain's been there for many years. And so what we did with this study, we looked at the content specifically. People always ask us, so what do you do when you do one of these neuroscience education? Sounds pretty neat. And so we just want to quickly clarify this. First of all, we talk about the neurophysiology, how the nervous system works, how it processes this thing called pain. There's no anatomical references. We don't really go through anatomical models. Good disc, bad disc. Good knee, your knee. We don't do any of those. We actually get away from those models, as David so beautifully stated there. There's no discussion of emotional or behavioral aspects related to pain in the studies they've done. Nociception, nociceptive pathways. Yes, there's information, warning signs, but pain is a brain construct, how these warning signs show up in the brain. Discussion of neurons, how neurons actually work instead of just really good neurons, bad neurons, if you will. And then synapses is what we cover. Action potentials, I'll honestly tell you guys, I've been doing this for about 20 years, been guided by David for many years. I draw action potentials probably more than anything else in the clinic. Every patient of mine has a stack of action potentials they take home. They fill it out throughout the day when they sit, stand, walk, etc. And so they will do it quite often. Nice way to track it, by the way. Spinal inhibition and facilitation, as Lorimer said. Upregulation, downregulation. This is what people cover in this session. Peripheral sensitization, central sensitization, plasticity of the nervous system, the fact that it can change. It's not that long ago that we believed that you were hardwired. Everything stayed the way it is. And wow, how amazing. These things can be changed, drastically changed, giving a patient a little bit of hope. You mean it doesn't have to stay like this? No way. We can change that, right? And then I have to mention this, that the Explain Pain book has been used as a source in a lot of these studies and obviously contain a lot of this stuff in there. The educational formats are typically done one-on-one, and Lorimer has done a few studies where they've done group sessions. Currently, best evidence shows the best way to educate patients about pain is one-on-one if you want to get the best outcome. Group sessions are a lot cheaper, and it's probably the way to go for the future. But right now, it's probably the best if we do it one-on-one, because you guys have all done this. You sit with a patient, you work your way through it, and then ultimately they sit with you in a group session. They say, this is great, but what about my pain? Pain is such an individualized thing. And we have to discuss that as well. What do we use in these sessions? Prepared pictures. You can take any pictures into it. We use all of those. Examples. Good example is this old ankle sprain. I borrowed it from Lorimer. The notion of showing a patient this and saying, hey, Sally, would that hurt? Well, of course that would hurt. Yeah, but would it hurt if there's a bus coming, speeding straight at you? Would that ankle hurt? Probably not. You'll get out of the road. The reconceptualization, thinking about it, whoa. That's amazing stuff. And so we use a lot of these examples. We use metaphors. One of our favorite metaphors is that the nervous system is an alarm system. Can be turned up, can be turned down. Remember, again, not hardwired. Hand drawings. Sorry, I've been teaching a long time, and I often ask therapists to draw pictures, and a couple of you guys shouldn't be doing this, by the way, including probably whoever did that picture there. And then workbook of assignments. Lorimer has done a couple of studies where they've used workbooks of assignments. We like the notion because actually it makes people more actively involved, as Dave mentioned real quick there. And then the Neurophysiology Pain Questionnaire has been used as well, just as a tool to teach people, and you guys can look that up quite easily. I just want you to realize also that this is all done not just by itself, but also with a lot of other therapy. A lot of people look at neuroscience education. Oh, great, we're going to become psychologists. We're going to sit with somebody and just do psychology. No. In between, we're adding movement, exercise, mobilization. As Dave said, if you have to manipulate them, but move on. Stretch them, whatever you need to do. So it has been done with all of those. The evidence for it that we have found, basically strong evidence, moderate evidence for using these educational sessions of neuroscience to change a lot of these things that we've struggled with in chronic pain patients. The easy way to answer this basically is this stuff works, is what our systematic review has shown, and we're excited to bring this to you guys, and we know of several studies that are going on. So the one that Lorimer wanted me to talk about today is can we do something before you get into chronic pain? And I hate to tell you, I probably bit off something more than I should have, and that is spinal surgery in the U.S. There's a reason I look the way I do because of this. Anyway, first of all, if you're from the United States, you probably know this. Spinal surgery in the U.S. is increasing rapidly. Outcomes aren't that good. If you put all the data together, discectomy, laminectomy, fusions, kyphoplasty, vertebroplasty, about a third of people come out of the operation with the exact same pain, if not worse. The rehab that we are doing, the Cochrane review showed us it doesn't really work that well. And by the way, that is Mick, Thacker, and David. Mick wanted me to make sure that you guys know he's up top. And so, sorry. And then finally, we also know that patients don't get sent for rehab. Dr. Alison McGregor in the UK has done a study that has shown us they don't really typically send them to rehab in the UK. And if they do, about one visit. We just did a study that shows doctors in the US, same thing. They don't really send them to us because we break them. All right, so to develop this program real quick, I'll run through real quick. There's 6 parts to our program that we've developed, and I want to quickly run through them. We interviewed patients about their experiences with lumbar surgery. We've also looked at what are doctors right now telling people with surgery. And then we've also looked at preoperative education for orthopedics, to borrow from them. We just completed a study on the public perception of lumbar surgery. Viewing images, which I'll discuss in a little bit, and then this review. All of these have developed our program that we now have developed this preoperative program for lumbar surgery. So the first study we have, this happened a few years ago, we completed this one. We interviewed patients that just went through lumbar surgery. Sorry, I'm going too fast. Should I start over? Sorry, guys. We did this many years ago. When you're on a time frame and David Butler is here and you guys all want to listen to Lorimer, I'm sorry, Mick is here. So we interviewed patients. All right, thank you. We interviewed patients that just went through lumbar surgery, and what this study basically showed us is, they were happy with the information, but they wanted more, and specifically related to pain. And I've got some really beautiful data, qualitative data from these patients, begging, pleading for us, please, we want more information. And by the way, 50% of the patients that we surveyed 4 weeks post-operatively were very afraid that pain would get worse. And so the first thing we found was basically patients want to know more about pain. They told us that, and so we have to put that into our program. Number 2, we just completed this survey. We submitted it for publication, and I'm very glad to announce it's been rejected by just about every spine surgery manual in the United States, a journal. And so we're very proud of that because we expected that. So anyway, anybody have any leads on some magazines maybe for us? We'll put those in there. But this has been submitted. We're very excited. First of all, we interviewed surgeons in the United States and asked them, what do you guys teach patients before they go through operation? The easy answer is they'd follow what Dave said, a biomedical model. This is your joint. This is a good disc. This is your disc. Good disc, bad disc. All right? And so they focus on anatomy. The most common tool they use to teach people about surgery is a spine model with a bulging disc. If you guys look at that picture right there, would you ever go to the bathroom again if you saw that? Better yet, if you bend and that thing starts bulging a little bit, probably get a little worried about it. So these models don't work. They actually drive fear and anxiety for us. The next one we go through is basically preoperative education, and this is where you often have quite a bit of an argument with therapists. So the question always comes, if we do pre-op for orthopedics, knee replacements, hip replacements, which has been done, does it work? And unfortunately, if you guys look at it, not really. There are 2 systematic reviews, the one by Johansson in 2005 and the Cochrane review basically showed it doesn't really make a big difference. And this is a big fight right now in the US because a lot of hospitals are spending a lot of money on pre-op programs. They've shown very little efficacy. And so, unfortunately, this one didn't work. However, I want to quickly highlight this one. Of all the studies out there that we've analyzed, and this has just been submitted as well for publication, is that the problem comes with content. Again, it's very procedural. You're going to have this operation. You're going to sit here, stand there, walk here, lift this. All these kind of things are very procedural, but it doesn't teach people really about their pain. There's one study by McDonald that we found that basically taught people more about pain before joint replacement and showed significant changes. However, they only tracked it for day 1, day 2 post-op, that changed pain. The message is very simple. People are interested. They want to know about pain. And we as physiotherapists should take that message to them. We're so neatly qualified to do that. So again, pre-op focus is very limited, by the way. It doesn't focus really on a lot of pain stuff. A study we just completed basically is we're interviewing people in the United States about lumbar surgery. And it basically shows us they're afraid of surgery. A third of people believe lumbar surgery is successful and they would maybe do it. 50% more of them agreed that they would be afraid to undergo back surgery. I still keep to Lorimer's definition of pain. Pain is a perception by the brain based on perceived threat. How the brain perceives a threat. If you perceive lumbar surgery already as this huge, whoa, this is a big thing, just imagine how that brain goes into that operation. More than 50% believe that their side effects are very common, and then 76% of the respondents said they would try any other forms of reducing their pain before going through lumbar surgery. So our study basically showed these patients are afraid. The general population in the United States, very, very nervous and anxious about lumbar surgery. It's not really a good thing. A study which is in process right now, which Lorimer is helping us on, is we're actually having patients view images found on the internet prior to surgery. You guys will all see an image like that, and not to belabor the point, Lorimer has mentioned this in some talks before, but in picture A, I just hope that surgeon knows where to stop with that knife as he's going south, because I didn't sign up for that operation, and I'm very nervous because the surgeon's hand is about the size of the Hulk. And anyway, we're doing a study right now where we're comparing this to booklets, etc., and the preliminary results is these make people worse. It induces fear, anxiety as such. There's got to be a better way. So the easy way for me to finish up today is just saying that all of this stuff we had to do as a groundwork, putting it all together, has led us to the development of this program, which is actually now we're getting ready to get into the multi-center, multi-clinician randomized controlled trial, that we've developed a pain program, a neuroscience, a mini explain pain, if you will, before surgery. And we're going to track these patients for a year out and measure their outcomes. And that's kind of where we are right now, and that's, I think, what Laura's wanted me to talk about today. I just want to make sure I thank David Butler as my advisor and Dr. Ina Dinner, who's in the audience as well, for all their support and help during all my research, and a lot of other people. Thank you, Lars.
Thanks, Adrian. That's terrific, and I know there are many people here who would be pleased to listen to all of that. I've just seen your notes here, and they actually say, speak as fast as humanly possible. Terrific stuff, Adrian. The final speaker for today is Dr. Mick Thacker, who I can't see. There he is, the great Mick Thacker. I met Mick Thacker at the World Congress on Pain in Vienna in 1999, I think. And since then, there's a few things that strike me as remarkable about Mick. One is that he started his PhD under Patrick Wall of Melzack and Wall, and then Steve McMahon, who is the next version of Patrick Wall, I guess. These people do science probably better than, as well as anyone in the world, and Mick has therefore become a truly good scientist, and he is a clinician, and he's one of those people who manages to combine a ridiculously effective brain with a very nice manner and a very authentic humility. And I've managed to get to know Mick as a friend over that time as well. And I encourage you all to not be intimidated by someone who's really clever because he's also quite fat. Actually, he's not anymore. He used to be. Please, Mick Thacker.
Says, please wait. And while we're waiting, I've just been over there. I didn't even get a bloody seat. Right? So, physiotherapy is supposed to be a kind, caring profession. So some of you who sat down, offer someone who's on the floor a seat. Because my bum's really numb. And my left testicle. And I know you really don't want to know that, but I've told you anyway. So if you don't want someone's bum to be numb or their testicle, please offer them a seat. And also, if you do get to sit on the floor, you may even end up sitting next to someone who smells really nice. I just sat next to the nicest smelling person I've smelt for years. But unfortunately, she's Australian. Which means she'll have some character flaws. Dave, you're coming back up as well. We plan these talks together. And I say, what are you going to say, Dave? So he says, I'm going to tell them about educational ammo, Mick. So I put ammo on my slides, Dave. And you didn't even mention the word ammo. Or I wasn't listening. All right, so this is me. One of the things that we're trying to get across here in this workshop and other people who have spoken is this newer construct of what we think pain is. In the past, as Lorimer indicated, people have sort of stuck to quite rigid dualistic models based on the work of people like René Descartes. And as he suggested, I was fortunate enough to spend quite a significant portion of my life with Pat Wall. And Pat was anything other than a dualist. And he started to suggest that, we think about pain differently. And I think it's worth saying that, in numerous conversations with him, he used to say, look, mate, you physiotherapists have got a really good handle on it. What you need to do now is go forward and sort of demonstrate what you do to a wider audience. And he picked out specific names and sort of identified people who were already sort of well advanced in this. And this is an adaptation of Louw's mature organism model, but together with Dave and Louw Gifford, really changed the way a lot of people in our profession think about pain. I know they definitely influenced myself and have influenced Lorimer, and we're always grateful to you, Dave, for doing that, and Louw, who's not here. But this is a mature organism model, and it's suggesting that, look, we're processing sensory information. None of us are saying that nociception isn't important. We have a specialised but not a specific system to transmit information from the periphery, damaged signals from the periphery into a nervous system. But then it impacts onto this sort of nervous system, which we know is highly complex and highly influenced by many different factors, both physical, psychological, emotional, etc. And we make outputs. Now today, believe it or not, I'm not really going to talk about too many outputs, which many of you will be shocked about who have heard me talk before, because you'll know my passion is neuroimmunology and particularly trying to break down neurocentrism. Say, Lorimer, you're a neurocentric. But I mean it in the nicest possible way. So this is actually Lozzie's diagram from Physical Therapy Reviews a few years ago now. And I've adapted it by basically putting that arrow on the right-hand side. But you've heard this before, so I'm not going to dwell on it. But look what this sensory information is impacting on. It's impacting on cultural factors, previous experience, social and work environment, expectations, beliefs and knowledge. And this affects a change in the nervous system in the brain and the brain's output systems, one of which we actually believe is what pain truly is. Pain is an emergent output of your brain's decision of how to deal with some sensory information, but also maybe psychological information. Well, that made me sound like a dualist there, didn't it? So maybe I'll rephrase that another day. But Lorimer has used a definition over the last few years of pain is a multi-system output in response to something that your brain concludes is a threat. And what I would like to add to that is, don't forget that in the periphery you have immediate response systems. So a good example would be your inflammatory system. You release chemicals into the tissue after they're damaged. And that's a physical process. And we hope it operates normally in all of you and in our patients. It's the way in which you heal tissue or start to heal tissue. But after a short period of time, and we're talking very short periods of time, your brain is aware of those signals. In fact, it has a system by which some of the chemicals are directly delivered directly into the brain. And then the brain will operate a group of systems to either allow that process to continue, to amplify it, or to inhibit that process. And it's a dynamic interaction of higher and lower processes. And these are important constructs in how we're trying to understand complex pain situations in the clinic. And my job really today is to say, well, how do we get some of those messages across to some of the people we teach? I'm fortunate enough to be the coordinator of what seems to be regarded as one of the leading MSCs in the world that educates people, not only physiotherapists, but medics, nurses, OTs, basic scientists in the field of pain. And what I hope to show you in the next few slides is how we're trying to get some of this information across to clinicians. Because we were having a conversation when we were planning the talks about things like explain pain. And I know Dave and Lorimer are really comfortable. You know, their book that they put across is a wonderful resource. But it's not enough knowledge for us as clinicians. If we're using that as our textbook, as our gold standard for understanding pain physiology and pain in its wider construct, I think as clinicians we need to know more than that. Those two people who wrote that book know far more about pain than just about anybody else I've met. And the book is an incredible interpretation of that knowledge. But I think we do need to educate each other and our students to know more than that. Here we go. This is just about the output systems. I couldn't resist the slide. There is a curriculum, and I hope you're all aware of this, by the International Association for the Study of Pain. It's on their website. You can download it. It is about to change. Dave, Lorimer, myself and several other people have been involved in some of those changes to that curriculum. So there is a curriculum out there for pain. And like a lot of curricula, it actually suffers. And if you're not careful about to interpret it and put it into practice, you can have problems. So I want to sort of overcome some of those problems, particularly in my teaching with my students, and I hope that you would want to too. And there's 4 or 5 problems that have been associated with sort of normal, what I would say outdated sort of curricula. And that's that they often create artificial divides between basic science and clinical practice. And time is wasted on acquiring knowledge that is forgotten or is irrelevant. And Dave pointed out, you know, why we need to overcome some of these issues. Application of acquired knowledge is difficult. So it's very difficult to learn some of this basic science. We know that. Pain is an incredible language that is incredibly difficult to understand. You know, I as an Englishman, actually I'm quite exceptional as an Englishman. I speak both French and Greek very badly, so if you're French and Greek, don't talk to me. I'm just pretending I speak 3 languages. But, you know, normally it's a maximum of half. Very poor English, as you probably noticed. But, you know, it's difficult to acquire a second language for English-speaking people anyway. All right? And it's difficult to acquire the language of pain and the knowledge of pain. It's even more difficult then to apply it in the clinic. And we know that. We've been through that process ourselves. And the only way to overcome it is to practice and get it wrong. You know, I often say to students, look, what is your job while you're at college? What is your job while you're at university? And you get some interesting answers. But my answer is to get things wrong in a safe environment and to be helped to see why they were wrong. Yeah? And I avoid the term right, because I'm not sure what right is. All right? But hopefully I might show you a few examples of students getting things right. it's difficult to retain information that has no relevance or is boring. And that's demoralising. And so I think, as educators, particularly to other clinicians, we are legitimate in enjoying ourselves. We're legitimate in trying to make you enjoy a topic. Pain can be a really staid subject. But I hope this workshop and other experiences you've had of education in pain are enjoyable and have been enjoyable. And the worst thing, I think, is that these individual curricula have strong focus on individual specialities or disciplines. I'll give you an example. What I want to talk about is our introduction of an old teaching method, hopefully with a newer perspective. And that's problem-based learning. First sort of developed actually in France with an ex-soldier who found it impossible to teach in the way he'd taught before, but really picked up in medical education by Barrows in McMaster University in the late 60s. And PBL, a modern definition or a more recent definition, has suggested it's a curriculum development and instructional system that simultaneously develops both problem-solving strategies and disciplinary knowledge bases and skills by placing the student in an active role of problem solver confronted with an ill-structured problem that mirrors the real world. I love that last bit. An ill-structured system. We see case studies that have loads of information and basically are trying to tell the student, if you don't get the answers right, you're stupid. These ill-structured allow the students to go off and to look and to develop ideas. And I want to show you some examples. Okay, there's 3 key objectives of problem-based learning which hopefully overcome the problems with traditional curricula. And the first is that students acquire an essential body of knowledge that's retrievable, they can use, and it's specific to the domains, and it effectively addresses clinical problems. And I educate, the bulk of people I educate or I'm involved in the education are clinicians. They want that knowledge to get back into the clinic. Secondly, students develop the ability to use this knowledge effectively in the evaluation and care of patients, people who have real problems. Beautiful thing for Adrian to say, what if it's your mum? What if it's your sister? What if it's your best friend? Is it enough just to know lots if you can't apply any of it? And students develop the ability to extend and improve knowledge to keep up to date. And they want to keep up to date. And all of you here actually, we're talking to the great cleansed. There's a great many of you out there. It's quite a nice sight, isn't it? And as a socialist, it's sort of a bit like one of Fidel Castro's rallies. So I might still be here at 10, no matter what you say, Loz. All right? So it's important that we make and provide people with a system that allows them to be lifelong learners. More importantly, that we, make people want to learn for the rest of their life. So look, this is my ill-structured system, but it actually comes from a real patient. And this was a fascinating patient who had CRPS of the forearm. Okay? So they said, I have a funny-looking hand on what used to be my arm. And that's what I gave the students. And those of you who've done PBL, and we'll take you through a little bit of the anatomy, is you give that. And in my case, because I don't believe in overstructuring these things, that's it. And we give them a sort of a 3-hour session where I'm present in the room, really trying to keep quiet, which those of you know me know is virtually impossible, but if you're committed to this scenario, then you've got to follow through and see where they go with it and how they start to solve things. For those of you who are not aware of CRPS, and I hope the great many of you are, this is what it can look like. It doesn't necessarily have to look like this. Some people show you a redder limb. Some people show you nails that are brittle. But, and for those of you who can't spot it, it's the one as you look at it on the left. Okay? So, there's this person with a CRPS limb. And it's been well diagnosed and defined now in the literature. So I would urge you all to go, if you're unaware of how to spot it and how to diagnose it, to go to Norm Harden's paper from 2007. I don't want to dwell on the specifics of CRPS. But what's happened with CRPS in traditional approaches is people want ownership of it. And if we go to the literature, we can make a great case, and people have, of it being a neuropeptide-based disease, a neuroimmune disease, an autoimmune disease, or a disease of oxidative stress, vascular hypersensitivity. Other people have said it's a neurological disease. Some people have said it's a psychological disease. We could go on and on and on. People have wanted to find mechanisms within their own speciality for which then they can treat, and then they can own that condition and become the experts. But if we have a bigger perspective, the sort of perspective I tried to show you at the beginning, that Lorimer's talked about, that Dave and Adrian have talked about, it seems a ridiculous idea to have. All of these things by some incredible workers in the field. These papers are superb papers. They're very accurate papers. But is that really what CRPS is? So the Anatomy of Pbl, and to take you through it, and I'm going to show you sort of aspects of this process, is the sort of 8 acknowledged steps in sort of clinical Pbl. The first is to clarify unfamiliar terms. What do words mean? Define the problem. What's going on with this person with a funny looking hand at the end of what used to be an arm? Brainstorm possible hypotheses and explanations. Get your ideas out there. Yeah, arrange those ideas, though, not just to have mad ideas flying all over the place. Define some learning objectives, and this is all done by the students. And in our case, we do get them to elect a chairperson. Define learning objectives and bring in people's clinical knowledge, their experience, things that they've actually seen in the clinic. And then to gather information, to go off and gather information independently. And what we try to avoid is giving people specific topics. We want people to disagree, to interpret the same papers differently. We don't want one person to do pathophysiology and one person to do representational change, etc. We want everyone to be informed about all aspects of what the group have decided to include. And share the results of information at a feedback session as a second tutorial, and then to discuss clinical implication and experience. So in the next few slides we can go through reasonably quickly. But this is what my group of students who, any of you watch The Apprentice? Okay? In America you have Donald Trump. In the UK we have Alan Sugar. In Australia I think you have Paul Hodges. All right? Gurus who are allowed to sort of direct people in certain ideas. All right? And one of the things that they come up with was this model where they'd already done a traditional taught module on neuroscience, on research methods, and on the brain and pain. And I think this is important. The purists in PBL, and some of you out there may be included in that camp, would say you've got to be completely naive. This comes to Dave's points about educational ammo. You've got to arm people with something. So these people have had a very comprehensive grounding in research design so they can analyse papers accurately, in neuroscience so they can understand the terminology, and some of the modern concepts in how the brain functions. And this is what they decided to look at: peripheral pathophysiology, central sensitisation, constructs of neglect, representational change, pharmacology, interventional management, ablative techniques, etc. Rehabilitation, including physiotherapy, you'll be pleased to hear. Okay, and pharmacology again, for some reason. All right, and this is where to start. What they did is produced a nice sheet. They are all incredibly Mac-friendly, this group, so they can't resist using them. But what they did is put 3 columns. What we need to know. They need to know a lot. What we need. Can't even read it. Can you read that? Yeah. What we need to know twice, or what we know, sorry. What they know is quite a lot. What they need to know is not much, which would make you think they were the finished article already. And what we need to go off and find out. Sorry. But actually they went off and they did quite a comprehensive sort of reading program, and all the students fed into this, and they looked at diagnostic criteria, presentation, pathophysiology mechanisms, management, and clinical tests. And they were using drop boxes to put this information in. So we have no guarantee they read the papers, but within a 6-week period they turned over about 12,000 articles. No doubt that they hadn't read all of those, but incredible literature search. But from some of the things they fed back, we know that they did actually get a good appreciation of what CRPS is in a modern framework. And 3 students have agreed for me to show their work. And one of my more comprehensive students, Morten Haug, as some of you will know from Denmark, took a Danish approach. Very hard work in the Danes. And he couldn't resist making it look a little bit like a beehive. Bees are very busy, aren't they, too? But he's taken you from the periphery into the brain with specific information and ideas about what people think may be at the cause of CRPS. Equally, another one of my Scandinavian students, Ivan Hasvik from Norway, used a very good Norwegian approach, which was, there was a model out there. Why not use it? Did this make sense? And in relation to the work that they'd been considering, they felt this did make sense. So you're all right, Loz. You got it reasonably right. But one of my English students, an English girl, good old Brits, came up with a completely different model. For those of you who look at this, it's not a dualistic model, although when I had a chance to question her, I said, looks a bit dualist, mind and body separated. And then she pointed out to me that that sign in the middle, that number 8 on its side meant infinity, and it represented a mind-body continuum, which included peripheral pathology, representational change, etc. So I think PBL does offer us a way to incorporate some of these incredibly complex ideas that are involved in understanding pain. And I have no conclusion. Bye.
Thanks very much, Mick. Let's see if I'm just going to repeat what I said before, word for word. No, I'm not really. While I remember, at the conclusion of this session, we will try to finish in the next 10 or 15 minutes. And then there's an important announcement happening at the end of this that will be of interest to any physiotherapist interested in pain. So I encourage you to wait around for that. Don't run away. I'm not going to tell you what it is. Sorry that I had to do it this way. But this is just in case you've forgotten from what I said before. And, okay. I want to very quickly tell you about research that we haven't published yet because it's been rejected. But it's really, I think, comes back to, I'm very interested in teaching patients about pain. And David and Adrian in particular have highlighted the difficulties that we have making any mark on a patient's brain with new information, particularly something that's different. So very quickly, I want to tell you about something that we've been trying more recently. And that is applying really the sort of stuff that David was talking about, this idea of getting under the defensive radar. Isn't it a nightmare when your patient looks at you and possibly even verbalises, so you're saying it's all in my head? Isn't that just the heart sink moment? And I guess we're trying to present information in a way that gets under that radar. And the picture that I have in my mind is that we go and we sit next to the patient and start chatting with them. And without them realising, we've slipped in a bit of new information. And the way that we've tried to do that is to use the time-honoured approach of metaphor and stories, and I guess really engaging patients in something that they are emotionally involved in. I rely quite heavily on trying to make something funny with a patient. Maybe your strategy will just be to make it very sad or very frightening or arousing. I'm very interested to hear from those of you who would take that approach. So we've formally investigated the utility of presenting people with stories and metaphors that we then translate for them into something to do with pain. For example, and I will be very brief, but one of the metaphors is of a man who had an old car, and that motor vehicle started to develop a rattle, a noise, so he started to turn up the radio so he did not hear the rattle. And that process kept going for months and months until he offered to take me home from work one day, and I got in his car and he turned up the radio as loud as it would go. And then he gave me an empty wine cask and said, "You'd better put that just on your knee." And then we took off and the whole car was shaking. And I said, "Why is the radio up?" "Oh, because there's a loud rattle." And then we got to my house and he ran into a gutter. And the engine came through into the seat. And the rattle was all the engine mounts slowly coming off over 18 months. And then that story is converted for the patient into a lesson about pain. Pain is a warning signal. Don't just try to cover it up with TENS machines or with medications. So if you can understand the approach, there's an engaging story that's not at all confronting, and then we slip it in, the information in. So this package, we have looked at how many people read it. We give people the book and say, "Read this." Half of them read most of it. That's the idea of it. And 80%, so 4 out of 5, finish the book. And that's actually the first barrier has been crossed. It's very difficult to get people to read information that you give to them. This is the randomized controlled trial, and I'll be really quick, but we took people off a waiting list. We randomly selected them. One person refused to participate, and then we allocated people either a book of metaphors or the back book, which is an excellent How to Cope with Back Pain, What Should You Do? Behavioural Modification by Gordon Waddell and Kim Burton. It's an excellent book, but it's not in metaphors. And we measured a couple of things. We measured pain catastrophising and we measured knowledge of pain. And they're the two things I want to talk about. These people had very poor knowledge of pain biology initially. On this particular assessment tool, if you answer everything true, you'll get 50%, and these people got 25%. So they had a very strong understanding of the knowledge of pain, but their understanding was wrong. It was very René Descartes. 3 weeks later, we see an improvement in pain knowledge. They're better than chance now. They're still not fantastic, but we've made a shift that's maintained at 3 months. And then we crossed over the other group because there is the small chance that they just can't read, but they clearly can. They do the same thing. So there's a shift in pain biology knowledge. And that's also mirrored in pain catastrophising scale. So this particular sample was not particularly catastrophic, which was just actually quite an unfortunate quirk of the data. It means they're not as catastrophic as most people on a waiting list. But even in that group, we show a significant reduction, clinically significant and statistically significant reduction in catastrophising. That is, again, maintained. So our approach then is that once we've got under the radar, then we go in hard to provide a new understanding. And we rely heavily on explained pain for that, to provide accurate information, and Adrian has talked really well about that. The evidence, I think, is quite compelling for that. And that's not the end. We have to integrate that into your clinical paradigm and your way of approaching things and get people to practice, test it over time. We have other data from a randomised controlled trial where we We do painful yarns, explain pain, then a multidisciplinary pain management program, and we're seeing I would describe as huge clinical effects a year later. And we attribute that to the process of practice. We've got this new model, and I test it, and it seems to work, and then I test it again next week, and it seems to work, so the information sticks. That's the only bit that I wanted to add. In fact, we're due to finish. Before we do, I'd just like to iterate what the other guys have said. It is just fantastic for us to see a chock-a-block full room. This is exciting. I think I said on Monday night that physiotherapy and physical therapy and physical therapists are ideally suited to put up the spinnaker and to catch this wind. And no one else is doing that in our space. And I think of all the things that we're able to do, we're allowed to touch people and educate them in many different ways about their body, and that's a real advantage. And to see the room full suggests to me that perhaps the time is ripe. We're going to now run with this, and that's really exciting. It makes me proud to be part of the revolution. I said before that there will be an announcement. Is that Raphael or Martin? I've probably overplayed this now. It's pretty boring, actually. No, it's not. Raphael and Martin will talk to you. But before they do, I'd just like to say again, it is a privilege to work with you, David, Mick, Adrian, and it feels good. And I think we can put a lot of that down to the work that I think you started, David, and other people are taking off. There's posters looking at randomized controlled trials, beautiful work going on in Joe Niche. I'm sorry I don't pronounce that name well. Miramuse. We're not the only ones doing this, and it would be unfortunate to give that impression. This is not the David Loz, Mick, Adrian show. We just happen to have got the gig at this conference. But can you please join me in thanking our three wise men?
Good afternoon. I would like to thank Lorimer, David, all of us for having the opportunity to explain our project. We know that there is a revolution on pain management. You have already seen that this revolution is going on. The first point of this revolution is a new model on pain education on patients with chronic pain. So we would like, Martin and I would like to present you our project, which is to create an international network on physiotherapy and pain. And as my English is not as good as Martin's, I would like Martin to follow and to explain better than I what's our project.
I'm from Yorkshire, so my English isn't much better, I'm afraid. My name's Martin Hay. I'm chair of the Physiotherapy Pain Association. This is Rafael Torres.
From the Spanish Physiotherapy Pain Association.
Says it much nicer than me, doesn't he? We're really keen to try and see if we can get WCPT support for an international pain network. The Confederation currently runs two models, really. It runs a network which is a loose conglomeration of people with a like-minded interest. And then if the network is viable in the longer term, there's potential to move towards a formal group, which may then offer some form of educational content and conference building. We really want to start small but build it up, and hopefully the fact that so many people are here today is testimony to the fact that pain is now really grabbing the physiotherapy world. We've put some flyers around that have our contact details and a little bit of an outline on what we'd like to achieve with this network. We do need an expression of interest from as many people in as many countries as possible to go back to WCPT to say that there is a viable network that's worth supporting, and hopefully we can go from there. If people wish to contact Raphael or myself by email, please do so. If people want to stay behind just for a couple of minutes and just speak to us individually, that would be great as well. But the more people we can get involved in this project, the more likely it's to go forward and be a success. Please feel free to pass on the information to like-minded colleagues that may not be here, or people back in your own countries that you think might be interested. I'd just like to thank Lorimer again for giving us the opportunity to use this forum to try and promote this opportunity. Thank you very much.
Thank you.